Hello, athletic training students. We just finished an online lecture on analgesics and inflammatory drugs. And then I thought, okay, this is probably the next best chapter to go into, kind of pathologies that might cause an inflammatory response, but aren't linked necessarily to pain and or inflammation caused by pain. So today we're going to be talking about drugs that are going to be used to treat colds and allergies, because the third most commonly used and abused medication over the counter are going to be drugs in the cold and allergy kind of category. So let's go ahead and get started. I'm not sure why this table is kind of cut off, but I promise you in the actual PowerPoint within the class, it is not. So we're looking at a table, and the purpose of this table really is for you to see kind of the characteristics of the common cold versus allergic rhinitis. The hope is that maybe it'll help you kind of differentiate between the two when you have a patient walking into you, right? And you're trying to figure out, do they have a common cold or is it an allergic rhinitis? So as we look at this table as a whole, right, one of the things that we kind of want to really ask ourselves is, what are some of the differentials, right? So let's look here. I'm going to go down this and I'm going to look at the differentials. The common cold is communicable. What does that mean? It means that we can transfer it from one person to another. Allergic rhinitis is not communicable. We're not going to get it from someone. We're usually born with it. There's usually a genetic predisposition to allergic rhinitis, right? Okay, next, we can avoid the common cold. We can avoid the common cold by avoiding people. Just kidding. That was a joke. Haha. But we can avoid it by having good kind of cleanliness best practices. So washing our hands, avoiding crowds, staying home when we're sick so that we don't pass it, right? You can, with allergic rhinitis, you can try to avoid it, right, by avoiding allergens. But the reality is, what if your allergen is in your house, right? The duration of the common cold versus allergic rhinitis is also different, right? The common cold, it's at 7 to 10 days max, and you have kicked the common cold. Whereas with allergic rhinitis, it's going to depend on if it's seasonal or perennial, right? What does it mean if you have a seasonal allergy versus if you have a perennial allergy? Great. Hopefully you said seasonal is exactly that. It's seasonal. It most often happens with, often fluctuates during the seasons, and usually is a result of exposure to an outdoor allergen, right? Whereas perennial, that's going to be more constant. It's going to be more consistent, and it's most often associated with indoor kind of allergens like mold or dust mites and things like that live or exist within an actual house. Yes. If we look at the common cold, one of the things that we know about the common cold versus allergic rhinitis is allergic rhinitis is a histaminic response, whereas the common cold is more of a response to a virus, right? So the histamine involvement is very minor in the common cold and is probably one of the key cornerstones of a patient with allergic rhinitis, whether that's seasonal or perennial. The next thing that we see with an allergic rhinitic patient is nasal itching. So if you've ever seen someone like rub their nose because it's itching so much, that is most common in allergic rhinitis, but not in your common cold. And then the sore throat wise, your patient will present with a sore throat for the common cold, but will not have a sore throat with allergic rhinitis. So we can see oftentimes that there are key differential things that we should be asking in our historical checklist, right? Ocular inflammation, so when the eyes get itchy and watery and all of those good things, very frequent in patients with allergic rhinitis, very rare in patients with a common cold. And then we talked about nasal itching already, rhinorrhea, runny nose, that's going to be present in both. But in terms of sneezing, for the common cold, it's very occasional and forceful, like you're trying to get something out. Whereas with allergic rhinitis, it's frequent, constant, and they're very light sneezes. So we can see there are kind of key differences between a patient who has a common cold and allergic rhinitis. What I'm hoping is that you can use this table to say, what are the history questions that I'm going to ask? A patient comes in, they aren't feeling good, they're sneezing, they're coughing. What are some of the key historical questions that you would get from this table that you actually want to ask? What would be some? Great. So like if you said, okay, how long would be a question. How long have you had the signs and symptoms? 20 days. We know it's not the common cold, right? What other question would you ask? Does your nose itch? Do you have a sore throat? What about your eyes? Talk to me about your eyes. You're going to ask yourself, clinician-wise, do they have a cough? So we can see kind of these kind of key cornerstone historical questions that help us really determine what type of kind of pathology we're dealing with when the patient walks into our clinic. So I keep coming back to this image, right? And this time I came back as a reminder in this particular region, right? So as a patient experiences the common cold, particularly allergies, those histamines, those leukotrienes, and those prostaglandins are going to get stimulated. The allergen kind of inserts somewhere within the nasal pathway, and automatically we have some type of immune response. And we're going to talk through that in a separate slide. But what happens when we have that immune response? Remember, those histamines are going to increase capillary blood flow. They're going to increase vascular permeability, and doing those two things allows fluid, right, to move into the nasal pathway, into the oral pathway, where we start to create things like phlegm and or mucus, which are responsible for causing sneezing, right? So we have to keep that in mind, that not only are we talking about this from an injury perspective, but we're also talking about this from a common cold or allergen perspective. And particularly what we're really looking at is this here. When we talk about allergies, what we're really referring to is histamine, and histamine is going to be a key contributor to the extent of allergic reaction that a patient might be experiencing. And then last but not least, in the previous lectures, we talked a lot about the cyclooxygenase pathway. By now, as far as I'm concerned, y'all should be pros on the cyclooxygenase pathway, right? And then I said, we're going to talk about leukotrienes at some point in time. And today's that time. So we're looking at the lipooxygenase pathway. One of the things, there's many things that the leukotrienes do, but today we're talking about the common cold, and we're actually talking about allergies. And so we're talking about how do leukotrienes contribute to the reaction that we see when we're cold or when we have an allergic response? And when the leukotrienes are released, in addition to the other things that they do, they also cause an increase in mucus production, which is why we sometimes get congested, for example, right? It's why sometimes we sneeze. They apply pressure to the nasal cavity and force us to sneeze. So we can see on the right-hand side, right? On the right-hand side of this sheet, that we have these leukotrienes that are also now being released and are causing other deleterious kind of signs and symptoms, one of which is an increase in mucus production. We don't want that in the common cold or allergic rhinitis, right? We can blame our leukotrienes essentially when we have, for example, let's say a stuffy nose. So before we start talking about the common cold or allergic rhinitis, I think we should spend a little bit of time looking at the respiratory tract. Your textbook doesn't do it, and maybe I shouldn't, but I feel like the more you know, the better. So if we're looking at this respiratory tract, we have the upper respiratory tract and we have the lower respiratory tract. And some of the drugs that we are essentially going to be taking that are over the counter will kind of target the lower respiratory tract. Particularly the expectorants will kind of decrease the viscosity of the mucus in the lower respiratory tract pathway. So essentially what we have is the nasal cavity, right? And then we have the oral cavity here. We have either a virus that enters into the body via handshake, rubbing of the eyes, putting our hands in our mouth, whatever it might be. And that virus kind of will travel through the respiratory tract pathway, right? Or the allergen will attach to something in the respiratory pathway and create an immune response or an inflammatory response. And both of those responses really are protective in nature, right? So either we're going to sneeze it out, right? Or we're going to develop some type of kind of immunoglobulin, which will then kind of grip the allergen up and try to eat it, right? But ultimately, when we look at the upper respiratory tract pathway, many of the drugs that we're going to talk about really, for the most part, are going to be focused on moving that mucus that's been produced from the release of those leukotrienes from the lower respiratory tract to the upper respiratory tract, where hopefully we can, dare I say, for lack of better words, spit it out and or blow it out, right? On this side of the PowerPoint slide, what we can see are different cough centers. And so this is one of the reasons that drugs that are going to be aimed at reducing cough in some way typically target our lower respiratory tract. And we can see why there are 3 kind of cough centers in the lower respiratory tract. And what I mean by that is when the mucus travels either from the nose and or the oral cavity from the upper respiratory tract to the lower respiratory tract, that mucus starts to build either, centrally, right or left. And so when that happens, if there's enough mucus buildup, guess what it's going to do? It's going to compress on the cough center and trigger your body to do what? To cough. Sometimes coughing is a good thing. If it's productive and we're moving fluid, it's great. But if it's a dry cough or it's keeping us up at night, we want to suppress that, right? So most drugs are going to be aimed at looking at suppressing the cough, and usually they target the lower respiratory tract because we have 3 cough centers sitting there. So let's talk through what happens with the common cold, because there is a key distinct difference between the common cold and allergic rhinitis, and it's really in the process, the physiological process. So we have an initial exposure to a virus, right? And what we know about viruses is that they can lie dormant on different types of structures for a few hours, right? So a handshake, which then leads to you rubbing your eyes or putting your hand in your mouth, for example, can be responsible for the transference of the virus to the actual body itself. Once the virus is in the body, then it attaches to our cells, right? And it begins the process of replication. The more that it replicates, obviously, the greater the signs and symptoms, right? So the quicker our body can fight off the virus, the less our signs and symptoms. But that virus starts to kind of replicate. And in the process of replication, of course, our body's natural defenses are going to be what? To kind of start the process of phagocytosis, but then also to release key chemical mediators. So the ones that we've been talking about the most, your leukotrienes, your histamines, your prostaglandins, we know that those are going to kind of increase inflammation in the kind of nasal pathway, but then in the respiratory pathway as well. And they're going to do that through increasing vascular permeability, right? Increasing blood flow, increasing mucus production, our leukotrienes. And then the kind of one key component that we haven't talked about yet is acetylcholine. Oftentimes when we're exposed to a virus, particularly that virus which causes the common cold, acetylcholine actually gets released, and acetylcholine will bind to cholinergic receptors within the nasal pathway, in the respiratory pathway, and also stimulate the release of mucus in those 2 pathways, right? So we can, in essence, when we're congested, when we have that runny nose, oftentimes we can blame these kind of 4 chemical mediators for kind of starting that process, but it's acetylcholine that's going to be most present in the common cold and be most responsible for increasing mucus production, right? That's ultimately what happens. And that mucus production leads to, if we were going to go back to this slide, if that mucus production is in the lower respiratory tract and is pressing on those different cough centers, it leads to some type of coughing, right? If it's in the nasal pathway, right, it might lead to lots of sneezing or itching or irritation in the nasal pathway. One key distinct difference is when symptoms actually begin. With the common cold, the signs and symptoms don't often begin until about 24 hours and maybe even 72 hours, right? It's all going to be dependent on, what do you think? Which component in this chart? You got it, right? How quickly that virus replicates itself and how much of that virus is actually present in the human body. So we have a slower onset of action for signs and symptoms associated with the common cold. This is going to be a key differential and characteristic along with this acetylcholine. Most often, actually all the time, when we look at someone who has allergic rhinitis, it's usually not an acetylcholine driven thing in terms of mucus production. So this is how the common cold happens. It's exposure to virus. And what this means is that oftentimes we cannot use antibiotics to treat that, right? The body's going to have to fight it off itself. Now, we have seen patients who had the common cold who are taking antibiotics, and I would argue that most often what happens is the immune system is compromised. And so in the midst of having the common cold, they actually develop some sort of bacterial infection, like a sinusitis, for example, where antibiotics might be a form of treatment to actually treat that bacterial infection. But antibiotics are not used to treat the common cold directly, right? They can't. It's a virus. Okay, next is allergic rhinitis. Remember, we talked about seasonal versus perennial. Your seasonal allergies are going to fluctuate, right, with the different seasons and are most often caused by allergens that live outside of the house. And then you have perennial, which is more consistent and more constant, right? Because it's exposure to mostly indoor allergens, right? So that person's going to probably experience the signs and symptoms of allergic rhinitis more consistently and more often because it's in the house, and we have to figure out kind of how to escape that. Now, I want to spend time here saying that because we're working with, it could be college level athletes, let's say, sometimes they don't develop that allergic rhinitis until they come to college and they're living in a dorm room, right? So their house may be allergen free, but when they move to college, for example, then they start to experience these allergic rhinitis signs and symptoms. So it could very well be that you have a patient who had no history of allergic rhinitis, and then they move to a different space or a different time, and then they have the symptoms, right? So how do we see the development of allergic rhinitis actually happening, right? Because it's a little bit different. It's a lot a bit different than the common cold. Common cold, we said, oh yeah, it's where you're exposed, right? Most often you're going to be exposed to a virus. So let's walk through what happens in allergic rhinitis. So essentially what we have is initial exposure to some type of allergen. And so we want to kind of use this chart over here as you're tracking with me. We have initial exposure to an allergen, right? That initial exposure is going to cause the production of immunoglobulin E antibodies, or IgE antibodies, right? And so we can kind of see these IgE-Y-like structures circulating throughout, right? And this process is called the process of sensitization, which means we are now becoming more sensitive to allergens either in the internal environment, indoors or outdoors, right? But the first thing that we have to have is an initial exposure to that allergen. So we have an exposure to an allergen. That allergen, the body goes, wait, you're foreign. I don't recognize you. You shouldn't be here. So then it develops IgE antibodies. Those IgE antibodies eventually circulate and attach to this structure right here known as a mast cell, right? The mast cells in particular that they attach to are the mast cells in the nasal passages, right? The mucosa of the nasal passages. And then it's this process that leads to what we call is sensitization, which means we're now sensitive to this specific allergen. And every time we come in contact with this allergen, we're going to have signs and symptoms. But the first thing that has to happen in allergic rhinitis is we have to have that initial exposure, right? So we have that initial exposure. We have IgE now attaching to mast cells, and that stimulates the mast cells to do what? What do you think? Release inflammatory mediators. Now, the most common inflammatory mediators that are going to be released are right here, your leukotrienes, your histamines, your prostaglandins. Most often, most of the research says that most allergic rhinitis episodes are histaminic driven in nature. So it's usually the histamine that's going to be causing most of the signs and symptoms. But all three of these chemical mediators are being released from the mast cells with the goal of increasing mucus production, particularly in the mucosal pathway of the nasal passage. And some of those signs and symptoms associated with increased mucus production, right, are going to be like rhinorrhea, sneezing, itching of the nose and the eyes, all signs and symptoms that are a little bit different from patients who have the common cold, right? So first we have to sensitize the patient, right, to the allergen. We have to develop the immunoglobulin E antibodies. Those immunoglobulin E antibodies have to attach to the mast cell over here. And so then once they attach to the mast cell, we have the release of chemical mediators, right? And so then that causes sneezing as a protective mechanism. It might cause a runny nose, for example. So there are key kind of structural differences between the common cold and allergic rhinitis. So what, in terms of whether we have a patient with the common cold or allergic rhinitis, these are kind of, allergic rhinitis is kind of lifelong, right? Common cold is going to be 7 to 10 days. So what is the goal of treating a patient with the common cold? Really, when you think about patients with the common cold, all we want to do is for the next 7 to 10 days, alleviate the discomfort associated with the symptoms, right? So whether that's runny nose or stuffy nose, whether that's body aches, for example, or chills, whether that's fever, we want to just in any way pharmacologically, if we're using drug therapy, we want to give them drugs that would help alleviate those signs and symptoms. Keeping in mind that, of course, antibiotic therapy is not effective if it truly is a viral pathology, right? Allergic rhinitis, the big goal for patients with allergic rhinitis is to prevent it. So are there ways that we can maybe clean the internal environment if it's perennial. If it's seasonal, are there times where we can avoid practicing outside would be an example. But ultimately, we would just want to work on treating the symptoms, right? That's the biggest goal. And so what we're going to talk about next really are kind of drugs and things that can kind of trigger different responses. So you all know that heat-related illnesses are actually a thing, right? And even though we're talking about common cold and allergic rhinitis, it is worth mentioning here heat illness. And the reason that we're kind of going to talk about it here is because a lot of the drugs that we will talk about, particularly your nasal decongestants and your antihistamines, oftentimes may cause vasoconstriction. And so if you have a patient who is ill and is taking like a decongestant or an antihistamine, and they're exercising outside, if they have vasoconstriction going on naturally within the body, we know that vasoconstriction is going to trap heat, right? So it may make the patients more susceptible to kind of heat stroke and heat exhaustion. So as we talk through medications that can be used to combat either allergic rhinitis or the common cold, also just keep in mind that some of the drugs and drug categories may also contribute to heat-related illnesses. So it may be wise if you're working in the summer and you have, the common summer cold or the common seasonal allergies, that we're looking at which drugs might actually create vasoconstriction and make a patient retain heat more often. And that's all I really wanted to say with this is we have to be aware that some of the drugs and medications that our patients would be taking in this particular chapter may contribute to heat exhaustion or heat stroke. So we have to be cognizant of that, especially in warmer weather conditions. So non-drug approach, because I do think that talking about non-drug approaches is extremely important. I think in this day and age, there are some kids who will grow up and will have never been exposed to any type of medication, right? And so we want to respect and honor those patients as well. So in terms of the common cold, it's really about prevention, right? So if we know that a patient has a weakened immune system, want to minimize the time we're spending in crowded areas to avoid exposure, right? In class, for example, we want to make sure we're covering our coughs and our sneezes with our arm, not our hand. It's one of the reasons we moved away from covering our mouth with our hand when we sneeze, is because then we could shake someone's hand and transfer a virus, right? And then we want to frequently wash our hands as much as possible, especially if we're touching multiple patients or multiple surfaces. And then in terms of non-treatment approaches for patients with the common cold, lots of increase in fluid intake because they might be sweaty and have the chills. Want them to suck on hard candy. Oftentimes that's done to kind of reduce the sore throat and dry throat mechanism. Use a vaporizer or a humidifier to reduce congestion, and or like nasal strips to open up the nasal pathway. So we can see they're really all are kind of alternative drug approaches that we can take with patients who have the common cold. And so we have to just respect our patients' choices. For allergic rhinitis, it's really all about prevention, right? So where we can, once they've been exposed kind of to that allergen, right, we want to minimize exposure to allergens as much as is possible. So that's going to be like making sure your house, your dorm room, your apartment, etc., they're all kind of dust-free. Same thing, your classrooms are dust-free, or you limit what students are allowed to wear. For example, for student athletes who exercise outdoors, maybe during peak allergy season, they exercise indoors, right? So it might be running on a treadmill, for example, doing swimming in an indoor pool would be other examples. Allergic rhinitis, you can also use the air filters. And then one of the things that we've seen that has been effective for patients with allergic rhinitis, particularly that of like dust, is you can put coverings over your carpet so that the dust mites, when that patient is in your room or in your clinical setting, doesn't come up, right, and cause an allergic rhinitic allergy attack. And then close windows and then use air conditioning. Now, I'll say that very lightly because air conditioning is expensive to run in the summer. But one thing that you do want to make sure of is that your air ducts are clean too, right? Because then it can contribute to allergic rhinitis. So these are all ways that we can prevent or treat the common cold and allergic rhinitis without using a pharmacological approach. But in the event that they're not getting better, and let's say they do want a pharmacological approach to treatment, that's what we're getting ready to kind of talk through, is the different types of drugs and drug therapies that we can use to help treat these patients over time. All right, so let's talk through some common over-the-counter combination products that we will see most often being utilized in the clinical setting. And to be quite honest, some of these we may carry in the clinical setting for our patients. Some of these drugs can be used to treat patients with the common cold or with allergies or both, right? So your antihistamines and your decongestants, also I'll circle that there, your antihistamines and your decongestants can be used to treat both patients with allergies and the common cold. And we'll talk about why. I'll define them in just a second. Whereas your antitussives, your analgesics, and your expectorants really don't work well for patients with allergies, but work really, really well for patients with the common cold. So this will become important when you're kind of deciding on which drug might be best for the patient sitting in front of you. Now, I'm going to dive way deep into this, but I do want to spend time at least defining each of these categories for you. As the name implies, an antihistamine is just that. It's an antagonist to histamine. So when we have a patient take an antihistaminic drug, that drug is going to compete for a receptor on the mast cell, right? And so it's going to bind to that histaminic receptor and inhibit the release of histamine from the cell, right? And that's advantageous because we know that if histamine gets released in response to an allergic response or a common cold, that it's going to, in the nasal pathway, kind of increase vasodilation, which leads to increased mucus production. And so that patient has congestion or runny nose or rhinorrhea, etc., right? So that's what an antihistamine does. It's a histamine blocker. Then on the opposite end of that spectrum, you have the decongestants, right? Your nasal decongestants, they act differently within the body, but they do the same thing. The goal is to not have as much mucus build up in the nasal pathway, right? So they cause vasoconstriction of the, receptors in the nasal pathway, which ultimately reduces nasal congestion. But they don't do that by acting on the histamine receptor. What they do is they act as what are called alpha adrenergic agonists. And so what do I mean by that? What I mean is they activate the alpha receptors, particularly those alpha receptors in the nasal pathway. And once those get activated, believe it or not, they stimulate vasoconstriction. So we have less mucus buildup in the nasal pathway, right? We can see how both of these working together would be way advantageous for our patient. So it is common, as you can see in this table, with our Alka-Seltzer Cold Plus medication, for example, to have an antihistamine and a decongestant in the same drug, right? Then we kind of get an additive effect of the two, an antihistaminic response and then also a decongestant response, right? So antihistamines and decongestants can be used in patients with a cold and an allergic, or those that have some type of allergic rhinitis. Now, as we move through the table, we have something known as an antitussive. An antitussive is a cough, I call it a cough stopper, but if we were really using the right word, we would say it is a cough suppressor or a cough inhibitor. And so we talked about this a little tiny bit when we talked about the cough centers, right? And the different locations of the cough centers within the respiratory tract. So an antitussive medication is given when the cough is not productive, when we want to stop the cough because it's dry and it's not moving anything. So in essence, what it's going to do is it's really going to suppress the cough center located in the central nervous system, or it's going to increase the threshold. In other words, as that fluid starts to build on that cough center, it's going to increase that threshold and decrease the sensitivity, which means more fluid can build upon it before the patient actually has a coughing mechanism. And again, that it can be a good thing or a bad thing, and we'll talk about that. You know what an analgesic is, so I don't need to spend time kind of explaining that. And then the last category is going to be an expectorant. An expectorant is a little bit different. It doesn't suppress the cough center, but what it does is it works by decreasing the viscosity of the mucus sitting in that lower respiratory tract so that it can be moved easier, right? So it makes coughing up the allergen or coughing up the mucus within the lower respiratory tract a little bit easier for the patient, right? Now, there are some medications in this chart that you can see ultimately have multiple types of drugs, right? This particular Alka-Seltzer Plus is actually a really good drug to buy, right? Like as I was preparing for this, I was like, this is amazing. So if I want to have a drug that will block a histamine receptor, will stimulate our alpha adrenergic receptors, will maybe stop the cough if I needed to and reduce the pain that's associated with the common cold, then your Alka-Seltzer Plus is like a one-stop shop, right? But if we look at this table and we go, okay, well, I really truly only want a drug for allergies, for example, one that is just going to reduce the histamine response, then which of these drugs would you choose? Right, you would choose maybe the Alka-Seltzer Cold Plus, right? We can see how this is a drug that could potentially be used for a patient with allergies, but then also a patient with the common cold, right? Which is why I said some of these drugs that I'm mentioning, you can certainly use for both groups of patients that we've been talking about. Now, the concern with some of these over-the-counter combination products is that as we increase the number of drugs in a given single dose, we also increase the risk for drug interactions, right? So even though our Alka-Seltzer Cold Plus is a great drug to have, it has 4 different types of drugs, all of which may cause some type of interaction, which may cause some type of adverse effect in our patient. So we have to keep that in mind as well. And then the biggest thing that I want to say to you as you look through this chart, is which of these drugs has what you need in terms of category to reduce the signs and symptoms that your patient is currently presenting with, right? I'm going to give you an example. If I have a common cold patient and that common cold patient comes into me and has joint pain, for example, then I am often going to choose a drug that has an analgesic in it, right? But if that patient maybe isn't reporting any joint pain, I don't need a drug that has an analgesic, right? So I might choose my Mucinex, which doesn't have the analgesic, right? But it's also a decongestant and is going to cause vasoconstriction and limit the amount of mucus that I have in my body. So as you start to recommend over-the-counter drugs, or as your patients are taking those over-the-counter drugs, we want to also make sure that they are taking the drug that would be appropriate for them by looking on the back of the bottle to figure out what type of product is in the drug that they are actually taking. And you'll find that when we do that, we'll actually see signs and symptoms resolve themselves. Oftentimes, patients are taking the wrong type of over-the-counter cold medication, for example. All right, so we're going to get into specifics. We talked about the antihistamine category. Its major role is to block the action of histamine, to block the release of histamine. So most often what we know about histamine, at least histamine 1, is that the histamine receptors live in the respiratory tract and in the peripheral blood vessels, right? And so if histamine in an allergic response or a cold response is allowed to bind to that cell, then it's going to open the floodgates, right? Increase mucus production because we have vasodilation and increased cell permeability. And that's what creates a lot of the congestion or rhinorrhea that a patient experiences, right? So many of the histaminic drugs that we are going to be talking about today are H1 histamine drugs. So antihistamine drugs. So we have Benadryl and we have Claritin, and I'm going to talk about them in different roles because there is a reason that we have competitor drugs on the market. So your first generation histamine drugs, and they're called first generation antihistamine drugs because they were the first developmental drug to treat allergic reactions from a histaminic response. And so when they were developed, one of the side effects associated with the first generation antihistamine drugs was sedation. So in other words, they caused drowsiness, right? And so Benadryl is an example of a first generation antihistamine drug. So over time, a lot of people who were developing these first generation antihistamine drugs and patients were complaining. They wanted to figure out, well, could we develop a non-sedating antihistaminic drug that patients can take and still function, right? And so then they developed what we call our second generation antihistamine drugs. So the Claritins, the Zyrtecs, right? Those are all what we call our second generation antihistaminic drugs. What does this mean? It means that they all work to bind to the H1 receptor and limit histamine from being released. It's just that the first generation drugs tend to bind to, let's say, the mu receptor and cause, let's say, sedation, whereas your generation 2s are not going to bind to that mu receptor and aren't going to cause drowsiness and sedation. So one of the things that you have to think through in a patient who has some type of histaminic reaction is the time of day that they're taking it, right? If it's during the day, then obviously we want them to be taking those generation 2 antihistamines. If it's at night, maybe we want them to sleep and maybe we don't want them to be itchy. And so maybe your Benadryl or your first generation antihistamines would be better, right? What we don't want to happen, and this has been reported, is that we have patients during the day taking those first generation antihistamine drugs and it impacts performance. So we want to be very, very careful with that. So in terms of use of antihistamines for allergies versus the common cold, one of the things that we know, I'm going to go to the right-hand side of the slide first, is that really the common cold isn't triggered by a histaminic reaction. Most of the signs and symptoms that we see most often aren't caused by the mast cells releasing histamine, but it can be used, antihistamines can be used to reduce mucus production for patients with the common cold. I would argue that there are other drugs like your decongestants that probably would work better for the common cold, but you can, if you have nothing else, an antihistamine in a patient with the common cold who is congested would certainly decrease the amount of congestion in that area. Where we really want to focus with antihistamines is in patients with allergic rhinitis. It is the mainstay of therapy. Most patients that have seasonal or perennial allergic rhinitis most often are prescribed or take over-the-counter antihistaminic drugs, right? It's going to decrease rhinorrhea, the itchiness associated with that, the within the eyes and the nose, and reduce the number of sneezes over time, right? So your antihistamines are going to be more effective for preventing symptoms, which is hard, rather than after the symptoms occur. So let me say that to you differently. If a patient is coming into you with sneezing, itchy eyes, etc., your antihistamines probably aren't the best drug of choice. But if you can predict that a patient with seasonal or perennial rhinitis is going to be going into an environment where they're going to be exposed to allergens, and you give them the drug prior to that, they are more effective at that, right? Because if it's after, your histamine has already been released, right? Your IgE has already bound to the mast cell, and so there's already a triggering of histamine that is already circulating, causing maybe a lower response, but the histamine is still there. So we want to use our antihistamines well in clinical practice, and so I would say make sure your patient is taking them before the exposure rather than after. Other uses of antihistamines and adverse effects. So if you have a patient who has dermatitis, so urticaria, itching, a full systemic rash, then your antihistamines are going to be good for that. We know that systemic rashes are also triggered by the release of your histamine, so an antihistamine would be an effective treatment for kiddos who have systemic rashes, etc. Interestingly enough, your generation 1 antihistamines have been used to assist in the treatment of insomnia if nothing else works. But the adverse side effect is when you wake up, you feel like you're slow and drowsy. And I don't want to use the term hangover because that implies drinking, but we can imagine what a hangover might possibly feel like, right? It also has been used in the prevention of morning sickness at very low doses, and then the treatment of nausea and vomiting. But the adverse effects, really the key one is the sedation, right? That the patient in first generation histamine has sedation, but in addition to that, sometimes it carries over, right? Which goes back to that kind of morning hangover component. Now, the first generation antihistamines also have this anticholinergic effect. So they not only do they kind of cause like vasoconstriction of the pathways, but then you start to see the dry mouth in that particular patient, for example, tachycardia and sensitivity to light. So we have to be careful with the first generation antihistamines. One of the reasons we really try only to use them in the evening or at nighttime is for all of these kind of adverse side effects that have been reported in patients who take them. So the next group of drugs are your anticholinergics. When we think about something that's anti, it's against cholinergics, right? The cholinergic receptors are binding sites essentially for acetylcholine. And we talked about this in the common cold. Acetylcholine, when it's released, will kind of stimulate or increase mucus production, right? So when we think about something that's anticholinergic, these are drugs that are gonna kind of inhibit the release of acetylcholine or prevent it from binding to its receptor sites. So in essence, what we see is a drying effect in the nasal pathway because of a vasoconstriction moment, but we also see a decrease in mucus production. So the only anticholinergic that we'll talk about and that is utilized in the field of athletics is Atrovent, which is a nasal spray. So you can see that down here. Patients presses the nasal spray into the nasal pathway. It binds to the cholinergic receptors, reduces or limits the release of acetylcholine, and what we start to see is the nasal passage will start to dry up in essence, and it does that by inhibiting the release of acetylcholine, right? So we're seeing direct mechanistic ways in which there are different ways, I guess, to reduce the amount of fluid in the mucosal pathway. So next up are our nasal decongestants. As I mentioned in the big slide, they are alpha adrenergic agonists. So what does that mean? That means they stimulate the alpha adrenergic receptors. And when they do that, essentially what they create is a vasoconstriction moment in the vessels of the nasal passages, right? So if we have vasoconstriction, we have a decrease in the amount of mucus within the nasal pathway, and then that in essence causes decongestion, right? So there's less congestion in the nasal pathway. So nasal decongestants are really good for patients who are extremely congested, right? You ever had that kind of stuffy nose that you blow and it's still stuffy no matter how much you blow it, right? That's when we want to kind of utilize our nasal decongestants, right? It can be used to relieve nasal congestion, whether that's from the common cold or allergic rhinitis, but we see that it tends to work best on the common cold. Now, with nasal decongestants, of course, there are different types. You've got your oral forms, which could be capsules, tablets, and syrups. But what's true and tried for our oral, regardless of which form, is there are two key kind of nasal decongestant drugs: pseudoephedrine, which is most often seen in Sudafed, and phenylphrin, which is seen in Sudafed PE. But those are the two most common types of nasal decongestants in the nasal decongestants that we might ingest. Now, we also have topical kind of nasal sprays, inhalers, and drops that a patient can use. So Afrin would be an example, an over-the-counter example of a nasal spray that patients can use. And then you can also have phenylphrin, which can also be a prescription nasal-based type of decongestion. So if we think about it this way, decongestion can happen systemically, right? Or decongestion we can go directly to the space, the nasal passage, and work through contacting those alpha adrenergic agonists in that direction and in that particular way. Oral nasal decongestants, to be more specific, they're used obviously to reduce symptoms of a patient who is congested, right? The oral decongestants are most preferred over the nasal decongestants just because The nasal decongestants can only be utilized, or the topical nasal decongestants can only be utilized for about 3 to 5 days. We'll get to that on another slide, but the oral can be utilized for an extended period of time. We have two different types of drugs that are most often going to be found in an oral nasal decongestant over the counter: pseudoephedrine and phenylephrine. So we want to compare the two, right? What are the advantages or disadvantages of a drug with one versus the other? What I can say is most of the research suggests that a oral nasal decongestant with pseudoephedrine is far more effective at treating a patient's congestion than that of a drug that has phenylephrine. So with that being said, what I always ask myself is, how often can they take it? As much as needed, which is great. The onset of action is going to be about 30 minutes. Duration of action is what I love, 4 hours. It's a long time, which means we have to take that drug maybe every 4 to 6 hours, right? Well, phenylephrine, essentially, it's less effective than your pseudoephedrine, has higher incidence of cardiovascular adverse effects, and it has a shorter half-life, shorter duration of action. So all in all, when we look for oral nasal decongestants or we recommend them, what we want to do is recommend a over-the-counter nasal decongestant that has the pseudoephedrine in it. It's just going to be more effective and last for an extended period of time. The concerns with oral nasal decongestants really, honestly, is that they stimulate the CNS. So this patient just might be like all over the place, right? In some patients, it has been reported to increase tachycardia and also cause like a vasoconstriction moment, not only in the nasal pathway, but in the periphery, particularly in the hand. You'll see it most often impact patients in the hand. And then one patient of concern is a patient with diabetes, right? Because if a patient has diabetes and we're altering how glucose is metabolized, that may impact their diabetic treatment. So we want to make sure we ask patients if they're diabetic and maybe recommend something other than an oral nasal decongestant. In terms of topical nasal decongestants, these are going to be ones that are sprays, right? They're indicated for short-term relief. So we're talking 3 to 5 days maximum. Anything outside of that, and the patient usually gets something called rebound congestion. So they're decongested, and then as soon as they stop using the drug, all the floodgates open and they're congested again. We call that rebound congestion. So the recommendation is to only use these particular drugs for 3 to 5 consecutive days. So a seasonal allergy patient, this would be good for, but it's going to be less good for a perennial allergic rhinitis patient because their symptoms are going to be more consistent and more constant, right? Now, there are less side effects associated with your topical nasal decongestants when compared to your oral. The biggest one that we see is local irritation in the actual nasal pathway, possibly leading to like epistaxis, aka a nosebleed. Two key drug interactions associated with both nasal and oral decongestants are patients who are taking monoamine oxidase inhibitors, which are antidepressant drugs, and then those patients who love their caffeine. Both of these can be catastrophic to the patient. In essence, what they essentially do in patients who have taken an MAOI in the last 3 weeks, patients who are constantly drinking caffeine, is they increase blood pressure, causing a hypertensive moment. So you might cause like cardiac arrest in these particular patients. So nasal or oral decongestants are not recommended for patients who are monoamine oxidase inhibitors, and it may very well be that we reduce the amount of caffeine that a patient is ingesting when they're taking their oral or nasal decongestant. So things to consider when you're working with your patients. Okay, let's talk corticosteroids. We can have a topical corticosteroid. Obviously, we can have an oral corticosteroid. So we can, I guess, talk about the two. If you're a topical corticosteroid, what they're really saying is that is a nasal spray. So these are most often going to be prescription based, but we do have some that are over the counter, right? So your topical corticosteroids, like your Flonase or your Nasonex, for example, they're going to inhibit production of all of your inflammatory mediators. So what would some of those inflammatory mediators be? You guys tell me. Prostaglandins, your leukotrienes, what else? Your histamines, right? So they're going to inhibit the inflammatory pathway. And so then that's good. We have less histamine production, less leukotriene production, which means less mucus production, right? They're often used to treat symptoms of rhinorrhea, itchiness, sneezing, etc. They're probably the best therapy, yet they're not the first therapy that we go to most often because most of them are prescription based. And if that isn't working, if your nasal decongestants aren't working, then you can certainly go to an oral corticosteroid like, your prednisone, for example. But oral corticosteroids, we know that they have lots of adverse effects, and so they aren't used very often in patients who do not have severe symptoms. So what are some severe symptoms? Closing of the airway because of exposure to an allergen would be an example, but it's very, very rare that we use oral corticosteroids. Certainly the nasal corticosteroids are a plus in the clinical field. Our next group of drugs that we're going to talk about are going to be your nasal corticosteroids, maybe just in a little bit more in depth. So the nasal corticosteroids have a slower onset of action, and this is key because your nasal decongestion, right? You can use those for 3 to 5 days. They have a quick onset of action, but then we have to stop. Your nasal corticosteroids on the opposite end of that have a slower onset of action. So if we look at this slide, what we're saying is a patient will have to take this at least 3 days to see some benefits, but we'll have to use the spray for at least 2 to 3 weeks to see maximum effect. That is the opposite of a nasal decongestant, right? So the nasal corticosteroids are really good for those patients who have perennial allergic rhinitis, and maybe your nasal decongestants are better for those that suffer from seasonal allergic rhinitis or are suffering from the common cold, right? And there are very few adverse side effects associated with your nasal corticosteroids. Next up are your mast cell stabilizers. We know that the mast cells house histamine, right? So your mast cell stabilizers, as the name implies, it stabilizes, right? It decreases the release of inflammatory mediators from mast cells, particularly your histamine. The most common mast cell stabilizer that we have on the market is going to be Cromolyn. It's an over-the-counter nasal spray. You're supposed to do that about 3 to 6 times per day. It's most effective if the dosing is started before the event actually happens, which again, that's preventative, right? We think back to like our antihistamines, for example, that's also most often going to be preventative in nature. However, your mast cell stabilizers, they're less effective than the corticosteroids, which makes sense. The corticosteroids are prescription-based drugs. These are over-the-counter drugs, but they are better than your nasal decongestants, right? So there's a middle. Nasal decongestants would be low end, low scale. You have your mast cell stabilizers, and then you have your corticosteroid nasal sprays, right? So you have to choose. These ones will cause nasal irritation. And some people would say that that's okay because of the reduction in their signs and symptoms that they experience over time. The next drug category are your leukotriene modifiers. Remember that leukotriene lipooxygenase pathway, one of the things that we know about leukotrienes, right? And there's an increase in mucus production. So what do we do to modify the leukotriene pathway? We have the patient take something called Singulair. Most of you have heard about this as it relates to asthma, but there is actually both a pill version and then also an inhaled version of Singulair, right? It's going to be the same dosing form and regimen as in your asthma treatment. And again, this is going to be less effective than corticosteroid nasal spray. So all in all, if we had to choose something, I personally would go with corticosteroid nasal sprays first. And then depending on my patient, you'll have to choose which of these drugs might work best for a patient who has allergic rhinitis. Now we move to something that's probably going to be utilized more in patients that have common colds, the expectorant drug. The expectorant drug is a drug that is used to decrease like the thickness, the viscosity of the mucus that's sitting in the lower respiratory tract, right? If we can decrease the viscosity of that fluid, then we know that it's easier to move through the lower respiratory tract into the upper respiratory tract where it can be expelled from the actual body. Now, what I want to say with expectorant is we absolutely want to use this in patients who have the ability to cough, who can cough forcefully, who can move mucus through the respiratory tract, and who have what we call is a productive cough, one in which phlegm and fluid is moving through. The most common type of expectorant is guaifenesin. And if we were to go back to that big chart, we would see that guaifenesin is really the only expectorant that's most often used either alone or in combinations with other things like your antitussives, your antihistamines, or your decongestants, right? Now, if we really want this to work well, if we want to take an expectorant drug and we want it to work well, we know that it's going to decrease viscosity. So we would take the expectorant drug with a fluid, even if the expectorant is an actual fluid, drink some water. And the beautiful thing about that is it's going to cause pressure on the cough center and cause, guess what, facilitate expectorant activity or coughing, right? But let's say we have a patient who doesn't want to take an expectorant. Well, what are some non-drug therapy things that we can do? Keep drinking water. It's going to press on the cough center and kind of thin the mucus out. And we can keep the air humidified so the throat doesn't dry and they're not producing a what we would call is a non-productive cough. Moving on, our antitussives. Remember, we said those are cough suppressants. Those are way different than expectorants, right? Your expectorants, we're reducing the thickness and viscosity of the mucus, but we're allowing the patient to cough. Cough suppressants, on the other hand, actually reduce the cough, and they do that by increasing the cough center threshold or increasing or decreasing the cough reflex in the CNS, however you want to think about that, right? It's indicated for control of a non-productive cough. So listen to me. This is a cough that is dry. You don't hear fluid. You don't hear anything moving through the chest. We never want to suppress a cough that is productive. By productive, I mean I cough and you hear things moving. Do not use a medication that has an antitussive if you have a patient who has a productive cough. Does that make sense? What would be some things that are non-productive? A cough that inhibits sleep or doesn't allow the patient to sleep, right? A cough that doesn't allow the patient to do what they need to do or to be effective in their sport, right? Those would be things, or a dry cough, right? Okay. Combination of antitussive and expectorant is illogical. So in other words, if we're suppressing the cough, we don't want to make the mucus thinner so that they will cough, right? It almost kind of counteracts one another. So make sure you're looking at the different types of drugs that are within the drug that you're recommending. And then, so your common antitussives, your dextromethorphan, your codeine, which is an opiate, and then your Menthol, which is most often found in like your cough drops, for example. Dextromethorphan is an over-the-counter cough suppressant. It's found in most of the cough syrups that a patient will take. It's available alone, but most often we see it in combination with other things. Most often Analgesics will be what it's in combination with. And the great thing about dextromethorphan as an antitussive is that there's very low incidence of adverse side effect. It doesn't cause respiratory depression, so you're not worried about a patient who will become unconscious if they, let's say, overdose on this. It can, however, be an additive to other CNS depressant types of drugs, so you want to make sure you're not using it in combination with your antidepressant drugs, your MAOIs, for example. Now, because it does have a little bit of menthol in there, then oftentimes you're concerned about the potential for abuse. But again, very rare in extreme cases. Codeine. Codeine is also a cough suppressant. It works at the cough center as well to reduce, to suppress the cough reflex. It is more effective than dextromethorphan in severe cough, which is why and that makes sense, it's a prescription-based drug. We see this, it usually mixed into a syrup form that you get over the counter. I've used it oftentimes for my kids if they've had like pneumonia, for example. The biggest concern with adverse side effects, to be quite honest, is going to be the development of constipation in patients, right? It is a controlled substance, so it has to be monitored, and it requires requires a prescription-based drug, whereas the other drugs that I've talked about so far, they do not, right? And so we're often going to see this available in combination with other drugs. So codeine is most often coupled with some type of analgesic, whether that's Tylenol or ibuprofen, and maybe even some type of antihistamine, most often in the clinical setting. My favorite types of drugs to use in the treatment of the common cold mainly are going to be those that I can put in my mouth that are sweet, right? So menthol is an example of that, and usually that is going to be like some type of it can either be a local anesthetic where we spray it. It can be in like throat lozenge form, for example. So like a cough drop would be an example of that. And what it does is once we suck on that, it kind of works within the actual oral pathway to kind of reduce the signs and symptoms that we have associated with like a dry throat or a sore throat. And it will also suppress the cough reflex as well. So menthol is a more natural way to treat some of the signs and symptoms associated with common cold. It can be found in different ways. And throat sprays that are over the counter, my least favorite. They taste terrible. Throat lozenges, right? So menthol and benzocaine are going to be the two common things that we see in throat sprays and cough drops. And then you can have creams and ointments, right? But those are going to be used to treat to kind of suppress cough. So an example would be like Vicks. Vicks, for example, if you put Vicks in certain places around your throat and in your nose, right, it has an antitussive kind of effect on the patient. If you haven't tried Vicks, go ahead and try it. It will have a cough suppressing mechanism, essentially. Your analgesics, we've talked a lot about this. Most analgesics, Tylenol in particular, is going to be found in many combination products, acetaminophen. It's going to relieve the pain associated with the sore throat, the headache, but I also think it relieves the pain associated with like muscle soreness. So anytime a patient who comes into the clinic and they have a cold, then I love it when I give them a common drug, cold drug, that has an analgesic associated with it. In addition to that, the beautiful thing about analgesics, particularly acetaminophen or Tylenol, is that it's antipyretic. So if I have a patient coming in who has a sore throat, headache, maybe body aches, and they have a fever, your Tylenol is going to be best. But some of the analgesics that are included in that are ibuprofen. So a big thing, we could keep going back and forth with this, but we know that with ibuprofen, we just want to make sure that your patient doesn't have a history of ulcers, right? Okay, I've said this multiple times, but nowhere else do I want to say it more often than not, is with cold medications in particular. Some of them do have aspirin as an analgesic, so we want to make sure that we're looking on the back of that bottle if we're working with peds to make sure that we're not giving them an aspirin-based common cold medication. So with allergic rhinitis, one of the things that we said was different is a common cold. We don't have eye itchiness, eye swelling, etc. But in allergic rhinitis, we do. Oftentimes you'll see like runny eyes, itchy eyes, etc. So there are drugs, ophthalmic products that can be used to reduce the signs and symptoms associated in the ocular region. The one that's, I guess, an NSAID and probably that can be used is your Acular, but most of these are going to be prescription based, right? The only one that I've seen that's an eye drop that can be used to treat ocular inflammation is Visine, right? And that's over the counter. And there are lots of iterations of Visine if you were to go to the pharmacy, right? Well, the one that's over the counter that can assist with any type of ocular issues that you have with an allergic rhinitis, your Visine is going to be great. And then you can refer out to a physician and they can certainly prescribe, right, an eye drop that would be more potent in nature, right? And we can see the great thing that we can see is they all have different mechanisms of action, right? Your antihistamine, take it in the eye, it's going to bind to the H receptors in the eye. Your corticosteroid is going to block all the way at the top, right? At that arachidonic acid. Your mast cell stabilizer is going to bind to the mast cells within the eye, prevent the release of histamine, right? Your NSAIDs are going to work in the cyclooxygenase pathway, and then your ophthalmic decongestant that's going to be a little bit different, right? What's it going to do? It's going to stimulate those alpha adrenergic receptors to cause vasoconstriction within the eye, and that's where we can see less fluid coming from the eye, etc. So you can apply all of these concepts to any of the drugs that we're talking about. I hope that you're learning that. I already said this, but I'm going to yell it to you because if you put this on the exam, I'm going to be upset. Antibiotics cannot be used to treat viral infections. They cannot be used to treat the common cold. They can't be used to treat any patient that has allergic rhinitis. The only time we see an antibiotic therapy being used in a patient who had the common cold is if, in fact, they develop other bacterial infections as a result of the immune system being compromised. Sinusitis is one of them, or ear infections, particularly in kids. So the children may have a common cold, but they may have also a bacterial ear infection. So that antibiotic is going to be used to treat the ear infection. Okay, done saying that. Now, we have something for patients with allergies known as allergen immunotherapy. And this is intense, the more that you read about it and the more that you learn about it. But what we know is essentially how allergies actually occur is we get exposed to an allergen, right? And then we develop those IgEs, and those IgEs attach to the mast cell, right? So we want to reverse that. And so what we'll do in allergen immunotherapy essentially is expose the patient to small doses of the allergen over time to allow the body to respond. And we increase the dose of that allergen every month, etc., until that patient actually gets used to it or develops a tolerance to the actual allergen. And I have a friend whose son is deathly allergic to so many food groups, and she's paying so much money to do this allergen therapy, immunotherapy. It is not cheap. We're talking, I don't know, she's $20,000 in just so her son can eat bread or go to school and she doesn't have to panic. So you expose your patient, the physicians expose the patient to the allergen in hopes that we develop that tolerance. The biggest risk is allergic reactions, right? So you're always worried, or the patient's always worried, right? And then patients with asthma, it may trigger an asthma attack. So great things happening in allergen immunotherapy, but yet there's such a huge risk to the patient since we're exposing them to something that they are deathly allergic to, right? So what do we do as an athletic trainer? And when we have a patient with a common cold or seasonal or perennial rhinitis, the biggest thing that we want to do is monitor the drug for effectiveness, right? With the common cold, if we treat the common cold for 7 to 10 days, it's the common cold. If we don't treat the common cold for 7 to 10 days, it's still the common cold. We're going to utilize drugs that would really reduce the signs and symptoms and make life easier for the patient, right? The other thing that we want to do is educate our patients regarding appropriate medication use and then monitor the side effects. So what I'm going to do is I want to go back to, where is it? I want to go back one slide to maybe here. And I want us to kind of think through this entire lecture because the entire lecture is really summarized in this slide, right? We have drugs that are antihistamines, which inhibit histamine from binding to the H1 receptor, which means we don't have vasodilation or increased cell permeability in the nasal passageway, and so it decreases congestion in that regard. We have drugs that are actual decongestants, and they do that by stimulating the alpha adrenergic pathway and stimulating vasoconstriction. We have drugs that are cough suppressants, complete cough suppressants. They're going to directly impact the cough center and the cough reflex, and we want to do that in patients who do not have a productive cough, right? We have drugs that are analgesic, and we use those in patients who have body aches, who have headache, right, whose throat might be sore. We have drugs that are expectorants. Those are drugs that are going to decrease the viscosity of the mucus in the lower respiratory pathway but still encouraging the patient to cough, right? And each of these drugs has their advantages and maybe even their roles in the process of a patient with a common cold and in a patient with allergic rhinitis. And you have to decide which of these drugs would be best in the treatment of the patient that's walking into you with the signs and symptoms that they're telling you. And that is the hardest task as an athletic trainer, but it is one that you have to be called to do. So thank you for listening to this lecture. I hope you learned a lot.